Hello, this is Dr. Kenneth Candido from Chicago, Chairman of the Department of Anesthesiology at Advocate Illinois Masonic Medical Center, and Clinical Professor of Surgery and Anesthesia at the University of Illinois College of Medicine in Chicago. Today we're going to describe cervical discography and provocation discography, I should say, for discogenic pain of the cervical spine. I have no disclosures related to this educational activity. Some studies have shown that MRI imaging is insensitive in the detection of painful cervical annular disc lesions as well as internal disc disruption. However, positive, meaning intense and concordant related pain, cervical discography in symptomatic patients can be demonstrated when patients either have normal or abnormal MRIs. That's a very common finding. Discography of normal discs should not be painful. In the cervical spine, the presence or absence of annular disruption has actually little relevance in the cervical spine, although intensely painful discs manifest tears either through or into the outer annulus. At C2, C3 level, there is no demonstrable correlation between MRI findings, discographic morphology, and a provoked response. The principle of provocation discography is that it's a procedure designed to identify a painful cervical intervertebral disc, as well as to depict its internal structure anatomically. It involves introducing into the nucleus pulposus of the target disc, as well as several control discs, meaning those not anticipated to be painful, a needle which is used to distend the disc by the injection of small aliquots 0.5 to 1.0 milliliters of a liquid, this being a contrast agent, in order to reproduce pain stemming from the disc, the sinovertebral nodes, the sympathetic chain, or even the cervical nerve roots themselves, as we'll discuss momentarily. If a particular disc is painful, then stressing it should reproduce the patient's pain. If the disc is not the source of the patient's pain, stressing it should either not be painful or produce an atypical pain response. However, cervical discography is liable to false positive results in patients with neck pain, where stimulation of any structure, even the zygapophyseal joints, for example, will similarly reproduce the pain. The International Association for the Study of Pain recommends an anatomical control, meaning levels which we don't anticipate to be painful, either above or below the targeted level. So, for example, if we're targeting the C4 or C5 disc, we would also wish to perform stimulation techniques of C3-4 and C5-C6. That's provided the provocation of the adjacent discs does not reproduce pain, of course. If the patient's accustomed pain is reproduced, we call that a concordant response. Any other form of pain production is known as discordant or dissimilar. This histogram shows the number of asymptomatic patients and patients with neck pain who rated the evoked pain at the intensity indicated by the numeric pain rating score. A false positive response can and does occur in some cases with provocation cervical discography if the threshold for reproduction of the pain is set too low. So, for example, we're looking for no less than a pain level of 7 out of 10 on a numeric rating scale, provided that the pre-injection or pre-stimulation pain is about 30 or 40% below that. So it makes no sense to rate a patient's pain at 6 and then derive a 7 with stimulation. Contrarily, we wouldn't want to select patients who are describing pain at 2 or 3 out of 10. That makes no sense with a mild level of pain. Provocation of a cervical intervertebral disc may appear positive in spinal segments where other elements are the actual source of pain, which is why the use of controls is exceedingly important. A cervical disc is distinct from a lumbar disc. First, and of course, the obvious feature being the smaller size relative to the lumbar intervertebral disc, but also the nucleus pulposus is situated more anteriorly. I'll show you a graphic momentarily. For a cervical disc to impinge, therefore, on a cervical nerve root, it must herniate both posteriorly or laterally, or a combination of posterior or laterally. Cervical nerve roots are protected from impingement by the facet joint, first and foremost. This imposes a bony wall between the disc and the nerve root, but also there's a stronger posterior longitudinal ligament, which is double layered in the cervical spine. This is another distinguishing feature of the anatomy of the cervical spine compared to the lumbar spine. I already mentioned that the material lies further anteriorly than in the lumbar spine. Therefore, it has to traverse a greater segmental distance from the nucleus to the posterior annulus to cause a clinically significant disc bulge, protrusion, or herniation. And the outer longitudinal ligament is indeed also thicker posteriorly. This represents the anatomy of the cervical region, showing the discs and the vertebrae themselves. This is an anterior view, and this is a lateral view. This shows that the nuclear material in the cervical spine is actually situated more ventrally or anteriorly than in the lumbar spine. Another critically important anatomical structure in the cervical spine is the esophagus, which tends to be housed or found more towards the left side than it is to the right, which is why many discographers will enter the cervical spine for discography using an exclusively right-sided approach with the head shifted towards the opposite side. So they're coming in from the right, and therefore the head will be rotated towards the patient's left side. The innervation of the disc, I said, has already been noted as multifold. Posteriorly, the annular fibers receive innervation from the sinuvertebral nerve. Anteriorly, we have the sympathetic chain, and laterally, we have the exiting spinal nerve roots themselves, which provide sensory innervation to the disc. So 3 major sources of innervation. Now we could conclude or hypothesize that these are the nerves responsible for discogenic pain, but we really don't know that to be true. We know that the cervical nerve roots do leave the spinal cord and travel laterally through the intervertebral foramina. If the disc herniates or is protruding posteriorly or laterally, it can impinge on these cervical nerve roots, the traversing nerve roots, and can produce a radicular symptom or a radiculopathy. If the disc herniates posterior medially, it may impinge on the spinal cord itself. Clearly, if the spinal canal is less than 10 millimeters in its aggregate dimensions, in its diameter, for example, and we have a herniation posteriorly, and it's of substantial size to impinge upon the spinal cord, this can result in quadriplegia, or more commonly, quadriparesis. The indications for cervical discography are multiple. It used to be as a prelude to cervical fusion, but we have expanded the indications for cervical manometric discography using provocation. Patients with persistent neck or cervical pain of a radicular nature where the MRI and other imaging studies have failed to identify a viable cause for their pain. Patients for whom the imaging is equivocal, for example, there may be a small bulge, but the symptoms are exaggerated in comparison to the anatomical deformity which the bulge produces. Those who are to undergo fusions, I've mentioned that, or who are going to have a revision surgery where we want to be sure that the targeted disc is in fact the pain generator and rule out contiguous discs, which is why we use controls as well as the targeted structure. And of course, in patients for whom traditional imaging techniques cannot distinguish a recurrent disc from scar tissue from prior surgery, for example. The contraindications are well known and include frank spinal cord compression. So if the canal is already congenitally narrowed, or there's been prior surgery with scarring, or the disc is exceedingly large and is already causing a myelomalacia, well, we wouldn't want to perform provocation discography in those individuals. Or a patient who is unwilling or unable to consent, or has a language barrier that can't be overcome, or they can't comprehend the instructions about providing coherent pain levels. Those would be absolute contraindications. If there's a known bleeding problem, or the patient's actively using anticoagulants or antiplatelet drugs, that would be an absolute contraindication to performing cervical discography. If the canal diameter is 10 millimeters or less, we would not want to stick a needle into the disc, pressurize the disc, and perhaps cause a furtherance of the consequences of this narrow spinal canal. Relative contraindications include allergies to contrast agents. We can overcome that in some cases, prophylaxing the patients with corticosteroids and Benadryl, for example, and continuing that practice for some time after the procedure. Pregnancy, known systemic infection, these are relative contraindications, or certain coexisting diseases, for example, or any disc level where there's a spinal cord deformity should be avoided or studied with extreme care. These are the contraindications. The equipment is well known to us. There are some authorities who might recommend the use of an ultrasound for the performance of discography in the neck. I don't. I use only exclusively fluoroscopy equipment, high-level, high-grade equipment. And I use a small hypodermic needle and syringe for infiltrating the skin and subcutaneous tissues, 25 or 27 gauge, 1 inch to 1.5 inches. For the actual penetration of the annulus fibrosus, I use a 22 gauge, 3.5 inch Quinky type cutting needle with a curve at the tip. And I utilize the curve to be able to steer the needle into position and minimize the requirement for retracting the needle and redirecting it through the tissues. If you've got a nice little 30-degree curve, about 1 centimeter from the tip of the needle, you can steer the needle into the target and avoid multiple needle passes, which can be painful for the patient. We also need local anesthetics, both for the tissues, and if you're going to be doing an analgesic injection into the substance of the disc, you might want to use 0.25% bupivacaine, for example. And non-ionic water-soluble contrast agents are very, very important. Some authorities would recommend adding an antibiotic to your preparation. So iohexol, for example, Omnipaque 180 or 240 is an acceptable choice for this purpose. Antibiotics can be given intradiscally, for example, cefazolin, 5 milligrams per ml, and ceftriaxone can be given systemically, so can clindamycin, and so can Ancef, amongst other choices. Patient preparation, the patient is placed in the supine position. The head is rotated to the contralateral side. So if we're entering from the right side, the head is shifted towards the left. We prep the skin and the subcutaneous tissues. Clearly, the skin is prepped with chlorhexidine or betadine. The subcutaneous tissues are infiltrated with the local anesthetic after first forming a skin wheel. I don't use sedation for discography. I want the patient to be completely alert and coherent and to provide verbal feedback about their symptoms and the pain level, but some authorities would authorize or at least advocate for the use of mild sedation. You've got to rule out bleeding diatheses, so it's obligatory to make sure the patient is, first of all, not taking an anticoagulant, secondary to look at the APTT and the APT and possibly the international normalized ratio when indicated. We come in from the opposite side, although some authorities would basically, forgetting the fact about that the esophagus is found most commonly on the left side and that entrance is most commonly performed on the right side, some discographers will enter the contralateral side from the patient's pain. So if the patient's having right-sided neck pain, they may come in from the left side, forsaking the fact that the esophagus is located mostly left. I typically favor a right-sided approach in most individuals. We start out with an anterior-posterior fluoroscope. We retract the sternocleidomastoid and the major vascular structures laterally, and we enter at a 30 to 45 degree angle from the skin, as will be seen. The right side of the neck is typically chosen. A 22 gauge, pretty much standard 3.5 inch styleted Quinky type cutting needle is advanced towards the superior margin of the vertebral body, just below the disc of interest. Careful to avoid, of course, the carotid, the jugular, the trachea, and the esophagus. And we do that by retracting these tissues laterally with our hand as we advance our needle. We palpate the needle with the index and third fingers from the non-dominant hand, and that allows us to retract the deeper vessels. Puncture is made at a 30 to 45 degree oblique angle using this 22 gauge, 3.5 inch spinal needle. Some would use a 25 gauge. I have found it to be much too friable and flimsy and bendable compared to a 22 gauge needle, but a 25 gauge needle is acceptable. You can certainly take a different trajectory with your needle by having that curve in the distal tip. The center of the disc is the target, and this will typically be found at several millimeters once the thick outer layer of the annulus fibrosus is penetrated. Confirmation of the needle tip should be attained using AP as well as lateral fluoroscopy, and then the injection phase commences. This is a graphic demonstrating the 30 to 45 degree angle from a midline. It demonstrates that we're placing the needle along the anterior border of the sternocleidomastoid muscle, and the needle is advanced ventral to the fingers. Here's an X-ray AP view showing the needle in place here, overlying the disc space. Here's an anterior, posterior, and lateral radiograph demonstrating needles at the C3-4 and the C5-6 intervertebral discs. Several more radiographs. This is the lateral oblique view demonstrating the intervertebral foramina, the vertebra, and the disc, showing that the needle is anterior to the facet joint, which is found right here. and anterior to the known location of the vertebral artery and the foramen transversarium. These are AP and lateral views demonstrating the needle in the cervical disc in its final position. And here the contrast has been injected. It forms a horseshoe shape anteriorly, posteriorly, and a little bit of a donut if we're looking on the lateral view here now under fluoroscopy. Several more images of 3 needles placed, C3-4, C4-5, and C5-6. The first view is a lateral oblique view, once again demonstrating the needles entering the disc. Here's an AP view and a lateral view. This is prior to the injection of contrast, and you can see that the needles are nicely situated in the central portions of the disc. Now contrast is injected, 0.5 to 1.0 mLs, or until there's a firm resistance. Or another endpoint would be if the patient describes pain during the injection phase, then it would be obligatory and mandatory to cease and desist further injection. And you can see a nice horseshoe-shaped image here of a nucleogram with the AP view and a nice little donut view here of the pretty much normal nucleograms on lateral imaging with the needles in place at C3-4, C4-5, and C5-6. As I stated, the average cervical disc will hold about 0.5 to 1 ml of solution. Caution should be used not to overfill and hence rupture the disc. Filling of venous structures does occur fairly commonly and is really of no or minimal clinical consequence, unlike, of course, an arterial injection. When we inject 0.5 mLs of local anesthetic, we can do that in a painful disc. It's an analgesic disc injection to determine whether, in fact, the pain reproduction and the reports of pain are actually legitimate. If the patient describes analgesia with these small volumes of local, you can say that the disc indeed was a pain generator. If there's resistance to injection, and there always will be some in the appropriately placed needle, make sure it's not too resistant and that it's not too firm and the patient doesn't describe significant pain, because you may actually be performing an annular injection, for example, or being close to the end plate, injecting against bone, and your needle needs to be repositioned at that point. CT scan imaging is sometimes undertaken. I typically perform it. However, unlike in the lumbar spine, the nucleogram, which is attained with the fluoroscopic view, typically suffices to give adequate clinical information along with pain levels, along with the manometric pressure that is attained, both the starting pressure, the opening pressure, and the maximum pressure. These are all important findings using a manometer to help you guide your decision-making when performing discography. While we're looking at typically one targeted disc, many discographers and many authorities would suggest performing discography in as many cervical discs as are accessible, from C3-4 sometimes down to C6-7. It's more difficult at C2-3 and C7-T1. At C2-3, we find the trachea is nearby and may represent an impediment to our success. And at C7-T1, we may encounter the cupula of the lung with the needle trespass resulting in a pneumothorax. Here's some examples of a painfully deranged cervical disc in a patient with a prior fusion, and you can see leakage of the contrast with annular disruption. Another patient here with a prior cervical fusion from a C2, C3 disc injection showing a full thickness tear with spillover of the contents of the injectate, both into the neuroforamen as well as into the epidural space. So these are severely deranged discs at the C2, C3 level, and the patient corroborated this as a painful disc by providing a high-level pain score. Another patient with a painful, partially deranged C4-5 disc with a lateral view here showing also some spread or leakage of contrast into the epidural space. And again, this would signify a very substantial disc rupture. Antibiotics, as I said, are not really controversial. The incidence of discitis is on the order of about 6.4 cases per 1,000 patients treated by, or at least examined, I should say, by cervical discography. It's a fairly low incidence, but I prophylax all my patients with intravenous Ancef or its equivalent, whether it's clindamycin, vancomycin very rarely, and I also use intradiscal antibiotics in some cases. There's good penetration of ceftriaxone into the disc at therapeutic levels up to 4 hours from an IV bolus, but the minimum inhibitory concentration effective against staph epidermidis, which is the usual agent responsible for post-discography discitis, was not exceeded. Intradiscal antibiotics, again, may be utilized in small 5 milligrams per ml concentrations, for example. Now, after we've done the injection or during the injection, we rate the patient's pain immediately prior as well as during it, as well as immediately afterwards. So pain is an important endpoint. We're also looking for the volume. How much did we actually inject? What was the pressure, the starting pressure, the opening pressure when we first saw contrast filling the nucleus pulposus, and the final actual pressure upon termination? These are endpoint characteristics. Was there a pain report? Was it concordant, meaning the patient's usual and customary pain? Was it dissimilar? What was the pain level? What was the starting pain level and the final pain level? Does it reach at least a 7 out of 10 on a numeric rating scale? What does the nucleogram look like? What's the morphology? Is it lobular, which is normal? Is it disrupted? Is there spread of contrast over the nerve root into the facet joint or into the epidural space? These are all important parameters to study. We also, again, lobulated mass is a normal nucleogram. If the disc is damaged and there are tears in the inner annulus, you may see a transverse pattern. If there are tears in the extending all the way to the outer part of the annulus, we may see a radial pattern of contrast spread. And if there's flow between the layers of annulus, we can see a circumferential pattern. These are all important observations to make to determine whether there's been some damage to the annulus or not. After evaluation of the nucleogram, that's when we decide whether or not we're going to proceed with the actual provocation phase. And as I stated, some discographers will actually inject small volumes of bupivacaine or the equivalent local anesthetic for analgesic purposes. If the patient improves after the analgesic, the inference can be drawn that the disc is a likely source of the pain. It's not conclusive, but certainly it's compelling information that the disc itself may be the source of that patient's given pain under those circumstances. Post-discography care, patients should be observed for no less than 30 minutes. Remember, these procedures are done with a fully flowing IV access to render the patient aid if there should be a complication. The patient is monitored, of course. I don't use sedation. Some people do. Ice packs can be placed over the neck. Acetaminophen can be utilized for analgesia, although some discographers will give a very short course of an opioid such as a hydrocodone 5 or 7.5 milligrams with 325 of acetaminophen up to about 3 days after the procedure. Muscle relaxants, I don't use them. Complications, discitis and abscess are the most horrific, nefarious, and sometimes slow to develop consequences. Hematoma can occur, of course. Quadriplegia has been reported, although I've never seen it. Post-discography disc infections are pretty rare. 6 cases in more than 12,000 patients in one study. The weighted average or the weighted incidence is 6.4 per 1,000 cases. I also advise to try to stay away from C2-3 when possible and C7T1 for anatomic purposes related to the trachea and the cupula of the lung. Very important. In conclusion, discography is an indispensable assessment tool to evaluate pain of a spinal origin, and it's no longer reserved for considerations for fusions. When the continuous evolution of spinal interventions and the growing recognition of discogenic pain as a major clinical problem, the demand for this procedure is certain to increase. We hope so. It's ideally suited for interventional pain physicians or interventional neuroradiologists. And when a skilled, knowledgeable discographer applies his art and craft to this, many patients will be well served by the useful information engendered by a successful and well-performed cervical discography procedure. I thank you for your time and attention to this very, very valuable lesson. Thank you and goodbye.